Welcome to Health or Consequences. I'm Paul Hattis from the Tufts University School of Medicine. I'm here with my co-host John McDonough, the T.H. Chan School of Public Health at Harvard. Our podcast, which runs under the Codcast label of Commonwealth Magazine, aims to bring our listeners rich opportunities to hear from a variety of people and on a range of topics tied to healthcare services and their financing, as well as public health issues here in Massachusetts. One very important policy space for sorting out what to do to advance healthcare services access, affordability, and quality is, of course, what happens in our state legislature. And with the new legislative session starting to get into higher gear, we find it timely to have with us today two very special guests, the two co-chairs of the legislature's Joint Committee on Healthcare Financing. Both new to their leadership positions, Representative Jennifer Benson from Lunenburg and Senator Cindy Friedman from Arlington. Welcome to you both.
Thank you.
Before we get into discussion of issues, I think our listeners would gain from learning really a little bit more about your background, including what you did before becoming a legislator, as well as your legislative interest and focus during your time in office until now. Representative Benson.
Thank you. So before I became a legislator, I was a mom and a college student and a school committee member and a local elected official in my town, and really kind of never planned to run for office, and it just sort of happened. My daughter convinced me to run, so that's why I ran.
Senator Friedman?
Well, similar to Rep. Benson, I never expected to be here either. I started out as a school teacher. I taught school for 6 years, and then I was in high tech managing hardware and software engineers for 20. After I left high tech, spent a lot of time making things and wondering what value they were going to add to the world. And then I met Senator Ken Donnelly and helped him with his campaign, and he asked me to be his chief of staff. So for the next 10 years, I was chief of staff, and we worked on a lot of behavioral health issues together as well as other things. And unfortunately, he passed away due to a brain tumor, and was really important for me to continue the work that we had started together, and so I ended up running.
And behavioral health has been a focus of your legislative interests and efforts up till now?
Yes, very much so, along with a lot of workforce issues and labor, but behavioral health has been a big part of what I've done.
Representative Benson, what's been your interest up to this joint point to coming to co-chair?
Well, it's been pretty varied. I coming out of the school committee and a public education advocate, and so I spent my first 2 terms on the education committee working hard in those areas, but quickly became very interested in electrical grid infrastructure and renewable energy, and so I've spent a lot of time working on environmental legislation as well.
Okay, thank you.
So welcome, both of you. Thank you for joining us today. It's really exciting to have you here. And one of the biggest issues, not just in Massachusetts, but across states all across the country and in D.C., involves the cost of pharmaceuticals. So today, April 11th, you're both chairing a public hearing on pharmaceutical issues. So we know that Governor Baker and Secretary Sutters also want to have action on pharmaceuticals this session. What action on drug regulation should we expect from the legislature and the administration this term? Why don't we start with Senator Friedman?
Okay. So I can't speak for the administration. I am very pleased to see that the governor, along with the legislature, is really interested in this issue. So it might be a point in time where we can actually get something done. So, of course, any legislation we're looking at that has to do with healthcare, we need to address pharmaceuticals. And I think the first thing that we're probably all looking to do is open the doors and better understand exactly what's going on around pricing and the pipeline and how that works. And so I think there's going to be a lot of effort on transparency to start with, because I think we need to know where we are and why these costs are increasing so quickly. It grew 5% from 16 to 17, the cost of pharmaceuticals, to to the state. So this is something we really have to look at, and I think the first place to look at is to transparency.
Representative?
I totally agree with that. And I think the House, we just released our budget yesterday, and we have an outside section relating to mass health specifically and pharmaceutical spending. And I think, this follows in line with one of the areas that the governor was interested in pursuing. So we're kind of coming out hot with this. And, our hearing today, I know I anticipate a pretty long and involved hearing. This is a complex issue. But luckily we do need more transparency. And I think, one of the basic things we need to do is we have this robust set of data and analysis done by several agencies here in Massachusetts. And one is the Health Policy Commission, which really looks at data and cost trends. We have to make sure we're getting more information in that scenario from both manufacturers and the pharmacy benefit managers. And I think that is a baseline that we just have to meet this session. But moving forward, we can see, if we look at those cost trends hearings, and I know we're going to talk about that maybe a little more later, we can identify, top areas of increases, and one of them is pharma spending, and the other big one is outpatient hospital services. So, it's pretty unique, and we're pretty fortunate here to be able to use data in a really productive and useful way in digging into some of these areas. And we can't necessarily figure out causation from that as a one-to-one, this is causing this, but we're starting to be able to peel back those layers and do that.
Is there anything that either of you would rule out in terms of state action, price regulation, anything, or is everything on the table at this point?
As far as I'm concerned, everything's on the table. And I think before we start, if we're really going to solve this problem, we have to have everything on the table and give it equal time in terms of research and understanding what will have the most effect, and what will serve the residents of the state, because that's really what we're focused on is how do we help people get access to health care that they can afford.
One thing we do have to be cognizant of course, though, is there's a lot of federal law around this issue. And we don't have free rein to necessarily do everything we'd like to do to sort of give the consumers more control over these prices. So, one of the things we've been doing is looking at what other states have done and what court cases have come out of that. Certainly, we don't want to have something that's immediately reacted to in a negative way in the courts and then have to start all over. So I think we can learn from what some of our neighboring states or other states around the country have done. But the other thing is, I think this outside section I would encourage everyone to look at in the budget really does go quite far. It's very similar to what several other states have done, including New York and California. And it gives, I think, the state and HPC in particular more control and more of a role in all those negotiations with manufacturers and holding them accountable.
Great, thank you. So let's turn to behavioral health. The administration also has a strong interest in behavioral health and integrating behavioral health into the overall health care much better. Either of you, do you have priorities, things that you would like to get done in terms of changes or improvements in terms of behavioral health in the Commonwealth?
Well,
Representative?
Sure. Senator Friedman, I think, has been such a leader in this area, so I'm going to let her sort of get into the detail. But what I will say is one of the reasons this is important, not only because it's the right thing to do, but we also can know through all this data collection that it's a big issue with comorbid conditions having a mental health issue. And so if you are a patient who is diabetic or have some other chronic disease, having also having a mental health condition really increases the costs and makes it trickier to treat those patients. And so, yes, it's simply the right thing to do because morally it is good to address these behaviors or these issues rather, but it's certainly very important when we also talk about the overall cost of healthcare.
Mm-hmm. Senator Friedman?
Yeah, so I couldn't agree more. So if we're going to fix our very broken mental health care, behavioral health care system, we need to address parity. And clearly, despite the fact that it's the law of the land and we have both federal and state laws for parity, we are not anywhere near reaching that goal. So, and this is really resulting in a lack of access to appropriate care, which exacerbates everything. So if you have a dual diagnosis, it's not only affecting your behavioral health, it's affecting your physical health. And so I actually have filed a legislation bill that will address parity, and it will get us one step closer to achieving that. So we would improve parity enforcement on both the commercial payers and the public payers. And it's kind of discouraging because the Department of Insurance has the authority to ensure that there's parity, but for some reason we're not doing as much as we can. So this very specifically lays out what the payers have to provide in terms of data measuring med-surg with behavioral health parity. It will address some of the barriers to access that are put up for people who are trying to receive behavioral health services. It'll ensure that group insurance commission is part of that parity effort, and it would ensure that there is consistent and fair application of medical necessity. There's also issues around provider networks that we're working on to ensure that the networks are adequate and that people can get access to behavioral health specialists when they need it. And it's very acute for children and adolescents trying to receive care. And then we have the issue of clawbacks, where the payers have a limited time to claw back payments that they've made to providers, and this is in turn is causing people. Actually, just one of the things that are causing people to leave the system, which is a big issue. We are now finding that it is harder and harder to get people to work in behavioral health and be part of the workforce, because not only of the incredibly low rates that the payers pay for behavioral health, and this is one of the things that we'll be looking at as part of parity, but also the strain of trying to meet the requirements that payers put on providers who are just trying to get treatment for people is enormous. And so people are saying, I can't do this anymore. And so it's becoming harder and harder for people to access behavioral health care. I think the ACOs will be a really interesting model that Mass Health is rolling out. But again, we have to ensure that when you have a capitated payment, that payment is enough and that covers what it means to take care of somebody with a behavioral health issue, and also what that means when you take care of somebody who has a dual diagnosis. So I think we have to pay very special attention to how that's going to roll out and ensure that it actually covers what is needed in order to take care of the whole person and stop siloing mental health.
Wow, great answers from both of you. Thank you. Paul.
So one issue getting a lot of national attention in our state from consumers and actually even the insurance industry is the whole issue of out-of-network or surprise billing. This is when somebody with commercial insurance, let's say urgently or emergently, goes to the hospital, and they think that's a hospital that's in network according to their insurance contract, but they encounter care from a physician, could be emergency room doctor, anesthesiologist, for example, who actually hasn't signed a contract and is so-called out of network, and therefore the patient receives a surprise bill with a lot of additional cost sharing as a result. I know it's been something that the legislature has started to turn some attention to. Representative Benson, any thoughts about that topic?
Yes, actually, this happened to me once. So I understand this very acutely. And I'll just tell you quickly what happened is I went to my dermatologist for a skin cancer screening, and the biopsy that she took was sent off to a lab. Well, I got a bill in the mail from this lab that apparently was not in my network. Now, I didn't have a choice of what lab this went to, and it just disappeared as I left the office. So So I had got several $100s of a bill from this lab. And, this is not something that the patient can really choose. These are things that are happening beyond the patient's realm of choice, of understanding. Like you said, it can be in an emergent situation if you're in the hospital and you have surgery. And so I think the most important thing we need to do is make sure the patient's not stuck in the middle. And as much as we can do to get insurers and providers working on this issue outside of sort of putting the patient in the middle of this billing and this issue and force them to then go back and negotiate it is unfair, because it's not due to a decision made by that patient. So I think that the legislation that passed last session in each of the chambers that addressed this, I can see potentially moving something fairly early on this. I think this is a really important consumer protection issue for patients.
Even moving this year potentially.
Sure.
Yes.
Yeah.
Okay. Senator Friedman.
Yes, I agree. I mean, I think we both are pretty clear that the patient has to be removed from this process, and that there need to be provisions to set up a fair and reasonable process for reimbursement, but it's really between the provider and the payers, and should not include the patients, because again, this is not something that they have chosen, that they're even involved in most of the time.
So last session, both the House and the Senate passed major comprehensive health reform legislation touching a lot of different aspects and issues and needs. One of the big issues was the variation in payments to hospitals that varies widely from some of the big academic teaching hospitals, very high, to sole community hospitals, very low. Both the House and the Senate attempted to address that, though in strikingly different ways, and then stalemated in July, and nothing happened. Should we expect action on that issue this session, and can you give us any sense of how there might be some bridging of the differences that were so evident last year?
We're looking at each other.
Senator Friedman.
Okay. Why do I get to go first? This is a very, very, very big issue, and it is not something that we're going to be able to skirt if we are really going to address healthcare costs. I think last session was unfortunate in that there was, in both the House and the Senate, a certain amount of turnover that really kind of got in the way of the process. It wasn't anybody's fault. It was just, given the complexity of this, it's very hard to come in have new players come in at the last minute and just pick up and just make a decision. Because we don't need to tell you, either of you, how difficult this is. So I really believe that we are going to work very hard to come to a consensus on how we can address this. So first, I've been in this position for now. It was 15 minutes. It's now 20. But what I see is that we have these wonderful teaching hospitals that we care very much about, that are very important to our state, to our country, to the world in what they do. They are beacons of innovation, and they are very important to us. That doesn't mean that there isn't something to get out of those systems, some costs that we can bring out of that group, that will allow them to continue be as wonderful as they are. We have a whole array of community hospitals, and they're very, very important. They're very important to the people in those localities, and for many, it's their only option. We have to ensure that at the community level, the right services are in place, that they're efficient, that they're high quality. But we can't just take money out of one place and throw it at something else. We have to be able to look at both ends of that spectrum, and first of all, ensure that the community hospitals have the services that the community needs. And that we're not wasting money where it's not needed, and we have to ask those teaching hospitals to come down a little bit. And I think if we can do that, if we can look at both ends of the spectrum and ensure quality and efficiency, then I think we can solve the problem, or at least start to solve the problem.
I think this is the most complicated issue that we have facing us, even more so than the pharmaceutical spending, which is a big issue. And, I think, one of the things that I've been talking about as I go out and have gotten this new job and go out and talk to people is that, we want to make sure that everyone has access to the right care at the right time for the best cost. And, part of that is a partnership between us and what we talk about and patients and what the choices they make. The community hospitals offer very, very important services, but unfortunately too many patients drive past them on their way into Boston for care that really it's not necessary to go to a academic medical center to have your child's tonsils removed, for example. And so, part of this is going to be also education around the choices that people are making, whether to go to an ER or to an urgent care center, whether to go to their community hospital, or when is the right time to actually take that ride into Boston. But, cost and price does not necessarily equal quality. And that's the other thing that I think we really need to do a better job talking with patients about as they're making these choices. We have some very high-cost hospitals that have great outcomes, but we have some very low-cost community hospitals that have great outcomes. And those outcomes are not significantly different in many of the measures that we measure. And so by choosing to go to a Mass General where it may cost twice as much as your community hospital, you're not necessarily going to get better outcomes. And so we have a lot of work to do to figure out not only how we as policymakers and as regulators change sort of the structure of how the funding flows to these different entities, but I think we also really need to have a real conversation and an educational product to help consumers, I use that term very loosely, but patients, make these choices as well. The other key thing in all of this is, we keep mixing up the idea that healthcare is a market. It's some sort of free market or some economic market, and it really isn't. People don't make choices the same way about healthcare as they do about buying a car. These are very, very different ways of approaching. And so hospitals have gotten into that as well. And I see a lot of community hospitals are also trying to compete in higher end treatments and, wings of hospitals to compete with academic medical centers, thinking that they're going to compete on this, through advertising in the marketplace. We have to watch for that too. I think that is potentially leveraging them in a way that is not necessarily the right level of care that they need in their community. So I think this is going to be much more complicated than even what was proposed in the legislation last year. I think if we really, really want to change this dynamic, we have to have a serious conversation about all the layers that feed into this problem.
So not trying to nail you down with a number, but could either of you put the odds on something happening this session on hospital price variation?
I think good. I'm going to be positive.
I think good.
Mm-hmm.
I think good. I think that we can't avoid it and say we're doing, we're covering the issues around healthcare. And I think that the rep raises a really good point, is it's going to take all sides to have an honest conversation about what level of care should happen at what stages and where. And I also very much agree with the point that we can't treat patients like consumers of buying cars. And I get worried when I hear people say, well, let's include the patient in the discussion of their health care, because that to me means often go shop around. And when your kid has cancer, You are not shopping around, okay? And it also adds this kind of piece where, well, don't trust your healthcare provider. Go, you have to go find the best price, and that's just not going to happen in healthcare.
Just briefly, last session we never saw any statement from the governor, his own position, or the Senate version or the House version. Are you getting any signals that the administration's going to take a different stance this session?
Yes.
Okay, great. Paul?
We'll look forward to hearing that piece along with what you guys tried to decide to do to take on this issue. But you both did recently participate in the annual benchmark hearing where you meet with members of your joint committee and the Health Policy Commission, and it does get into some issues tied to should the benchmark be changed, but also just general cost trends, as you noted, I think, Representative Benson. Any reactions or impressions on sitting through that hearing that lasted with you?
Well, I mean, I think the overall message and the overall outcome of this was very positive. And the positive thing is we have a benchmark that's currently set at 3.1 and will stay there, but actually our cost grew only by 1.6%. And that's pretty amazing when you think about what we see not only nationally, but what we were seeing up until really the post 2012 cost reform package. I think it's working. It's working. We still have, I kind of feel like it's a little bit like whack-a-mole, things that pop up that are still higher cost, and so we need to figure out how to address them. But overall, it's working. So
meaning that the process of the benchmark and the Health Policy Commission, what it does as a cheerleader around that benchmark, is that what you're saying?
Yes, and sort of the mechanism that is in place in order to keep costs down. I mean, because it would be one thing, yes, it's great to take in all this data and put out a report and tell people what's happening, but there are actual consequences if costs are too high. And that's really, really important. I think the next thing that we will need to address is, should the HPC have the statutory authority to go below the 3.1% benchmark? Because right now they can't. And
Stu Allman's asked for that recently at the last Health Policy Commission meeting to change the timing of when they can start to, in essence, set their own benchmark.
Correct. Because we want to continue that downward pressure. And right now we have, we're only at half of the benchmarks theoretically. So there's not as much keeping that pressure going, and so we want to maintain that moving into the future. So having that ability, I think, is really important for the HPC to be able to look at projections and have that authority.
Senator Friedman, your thoughts about that?
Yeah, I was really impressed with the hearing. I thought, and I'm overall very impressed with the Health Policy Commission and CHIA. I think they do a very good job and take their job very seriously. What became clear to me at the hearing and what continues to become clear is the incredible complexity of the system, and that complexity has got to be a major driver of the costs. And so I think we need to begin to reform the those cost drivers, but also we have to start looking at the complexity of the system and how do we remove complexity so that at least more money is going to actual direct healthcare.
When you say complexity, do you mean administrative costs?
Administrative
in the system?
costs, and and state regulations, and the relationships between the payers and the providers, and what now has to happen in order for the providers to actually do their job and get reimbursed for it. So I think we've just added a level of complexity that's enormous. I think it's really interesting. I mean, I think we've done an incredibly good job, but partners came in to me the other day and they were talking and they said, oh, we're so pleased we only increased by 1.9%. And my response was, yeah, but where did you start? And so it's, where else do we get to, someone gets to say you can only increase by 3.1%? Well, that's a huge amount of money in this system because there is, as we know, such an enormous amount of money in it to start with. So I do think we need to start actually, I agree that we have to start bringing that down and, bringing that growth down And I think the Health Policy Commission so far has done a very good job and has used their authority well, and I would ask them to continue, to look at that.
Okay, final question. We saved the best for last. So Medicare for all, big national issue, single payer. Let's toss this whole crazy, wacky system we have and let's go Canada or Great Britain or whatever. Big conversation nationally and in states. So if you were members of either the U.S. House or the U.S. Senate, would you be co-sponsoring the national Medicare for all legislation? That's question one. Question two, as co-chair, would you like to advance and report out of your committee legislation to establish a Massachusetts single-payer system? Who wants to go first?
All right, I'll
Representative.
go first. I'll dive in. Yes, if I were in the U.S. House or U.S. Senate, yes, I would. I think your examples of Great Britain or Canada are very, very different examples. I think, there's a lot of different ways to do single payer. I don't think that health insurance should be, made illegal. I think that people should have the opportunity to have wraparound, private insurance if they want it. But yes, I think there should be a basic level of care for every American. I have always been skeptical of doing this as a state on our own. And for a couple sessions, I actually filed a bill that would benchmark our spending to a theoretical single-payer system to look at what that would really to gather the data. The problem is that's only theoretical. So when there's a bill that's filed that says Medicare for all in Massachusetts, we don't have Medicare in Massachusetts, nor do we have any model of a single-payer system like that in Massachusetts. Our Mass Health program is run through insurers. So we're not a direct payer as the government of any real services in Massachusetts. So we don't have that model. So that in and of itself is a big hurdle. So it's not like you can snap your finger and have Medicare for all in Massachusetts. The other thing is, as a state, we are very much dependent on workers, companies from out of state. We have a lot of people in our surrounding state. I grew up in New Hampshire. Half my family worked in Massachusetts, right? And so if we're saying we want to have Medicare for all for Massachusetts residents and tax businesses to support that, they still are going to have employee benefit plans for all of their out-of-state workers. And so it becomes extremely complicated. So if you work in Mass and live in New Hampshire, what does that mean about your network and the availability? Because now if you're in Massachusetts and get sick, nobody takes insurance, according to the legislation that's been filed. It becomes extremely complicated. And of course, our academic medical centers, who bring patients in from all over the country and all over the world, would really be put, I think, at risk under this system. So I think to do it just on our own is extremely complicated, which is why I think we've seen it fail in Vermont and hasn't really gained steam in any other state. But from a U.S. perspective, we're the only industrialized nation that does not do this, and I think it's a shame. And we do it for many sectors of our population. We do it for kids, we do it for the aging, we do it for VA folks. We should be doing this for everyone.
Okay, thank you. Senator.
So in theory, I'm a big Medicare for all proponent, and I agree that at the it would be really hard to do it at the state level and not have federal support or do it at the federal level. My issue becomes is it's a really easy thing to say, but what exactly does it mean and how is it going to work? And I agree with everything that Rep. Benson said, but there's also the piece that is the public ready for this? And if the public isn't ready, it will be it cannot work because it will require such a shift in how we provide medical care and what our healthcare system looks like. And if people aren't ready for that, or desperate for something brand new, it is going to be very hard to implement. It is going to be a huge change for people. And, just their taxes alone are going to have to go up because we're going to have to cover healthcare for everybody, which is a great idea and is something we should be doing. So, but it's going to be a huge shift. And the other thing we can't ignore is that right now we ration healthcare all the time, but it's very obfuscated, right? It's not clear how we do it because people can't afford healthcare, and so they don't get a certain level of care. But when you go into a Medicare for all system, we're going to have to make decisions about how our tax dollars are going to be spent. And again, we're going to need some kind of consensus in order to be able to do that. So I am a proponent of this. In the meantime, though, we can do so much and have so much work to do to fix this system the way it is right now to make it better for consumers. Somebody came up to me and I gave them that spiel and they said, hey, it's a total mess. It doesn't work. How bad can it be if we go to Medicare for all? And there's some truth to that, but I just don't think we're ready. And one thing I am very supportive of is for the state to start to research this and get real data and make real comparisons about what would it look like and what would it mean and how would things change. So I'm very, very much in favor of that.
So thank you both very much for that. And it's great to have you both in the leadership of this important committee. And congratulations and good luck to both of you, Paul.
We'll look forward to having you back as you take on these complex but important issues. So thank you again.
Thank you.